Let's talk about the clinical phenotypes, the many confusing faces of CIDP.
When neurologists discuss this, we usually start by defining typical CIDP. This accounts for about 50 to 60% of all diagnosed cases.
Okay.
This is the classic textbook presentation that most doctors are taught to recognize in medical school.
What does typical actually look and feel like? If I am a patient developing typical CIDP, what am I experiencing day to day?
You would be experiencing motor weakness and sensory loss that is symmetric.
Meaning it affects both the left and right sides of your body equally. Yes, both legs, both arms. And crucially, it affects both the proximal muscles, the large muscles closer to your core, like your shoulders and your hips, and the distal muscle, the muscles further away, like your hands and feet.
So how does that present functionally, like in daily life?
A patient might come in complaining that they have trouble lifting their arms above their head to wash their hair in the shower, which is proximal shoulder weakness.
Right.
And simultaneously, they might be struggling to turn a key in a lock or button their shirt, which is distal hand weakness.
Wow, okay.
In their legs, they might have trouble standing up from a low chair because their thigh muscles are weak. But they're also tripping over their own toes because they can't lift their feet properly, a condition called foot drop.
And what about the sensory side? You mentioned numbness.
The sensory loss usually follows a similar symmetric pattern: numbness, tingling, or a feeling of wearing thick gloves or socks, even when barefoot.
Oh, that sounds so uncomfortable.
It is. And when the neurologist examines them, a hallmark sign is reduced or completely absent deep tendon reflexes. When the doctor taps your knee or your ankle with that little rubber reflex hammer, nothing happens.
The circuit is broken.
Exactly.
Yeah.
That's called reflexia. And finally, to meet the criteria for typical CIDP, these symmetric motor and sensory symptoms must have been slowly, steadily worsening or following a relapsing, remitting course for more than 2 months.
Okay, so symmetric, proximal and distal, motor and sensory, slowly progressive over 8 weeks. That paints a very clear picture, but as you noted, that's only 50 to 60% of the patients.
Right.
What about the other 40 to 50%? What happens when the chameleon changes its colors?
That is where diagnosis becomes an incredibly difficult art. We have a whole array of confusing clinical variants. Let's start with a major one called multifocal CIDP.
Multifocal.
In the literature, this is often referred to by the acronym MAD-SAM, which stands for Multifocal Acquired Demyelinating Sensory and Motor Neuropathy. Historically, it was also known as Lewis-Sumner syndrome.
Mad Sam. It sounds like a comic book villain. How does Mad Sam differ from typical CIDP?
The defining feature of MAD-SAM is that it is highly asymmetric. A patient might present with profound weakness, muscle atrophy, and sensory loss starting in just one single arm, or perhaps just one leg.
Just one side.
Yeah. The reflexes might be completely dead in the affected limb, but perfectly brisk and normal in the other 3 limbs. It looks incredibly patchy.
So it's not symmetric at all.
Not at all. It can easily be mistaken for a pinched nerve in the neck or back, or even an entrapment neuropathy like severe carpal tunnel syndrome, because it is so localized to specific nerve territories initially.
That sounds incredibly easy to misdiagnose. Then you have another variant called distal CIDP, which goes by another acronym, DADES.
Yes.
Distal acquired demyelinating symmetric neuropathy.
DADES is another major trap. As the name implies, it is characterized by symmetric sensory loss and weakness that is strictly confined to the distal limbs, the hands and the feet.
So the core is fine.
Right. The proximal muscles, the large shoulder and hip muscles, are completely spared. Because it primarily hits the long sensory fibers traveling all the way up from the feet, patients often present with severe sensory ataxia.
Ataxia meaning a loss of coordination.
Specifically, a loss of balance due to a lack of physical feedback. They literally cannot feel their feet hitting the ground, so their brain doesn't know where their body is in space.
That must be terrifying.
It is. They have a wide-based, unsteady gait. They might also develop a noticeable tremor in their hands.
But there is a massive diagnostic trap with the DADS variant, right? I mean, the literature mentions it heavily overlaps with a completely different disease category.
It does. When a patient presents with this specific distal sensory-heavy DADS phenotype, the neurologist has to be incredibly careful. Approximately 2/3 of patients who look like they have DADS actually turn out to have an IgM paraprotein condition.
Let's pause and define that, because we've talked about antibodies generally, but IgM paraprotein is very specific jargon. What does that mean?
Good point. Antibodies come in different classes, called isotypes. The most common one in our blood, the one that usually fights off viruses, is IgG immunoglobulin G.
Okay.
But there is another class called IgM, which is a massive pentamer-shaped antibody. It looks like a 5-pointed snowflake. In some people, a rogue clone of B cells starts overproducing one single identical type of IgM antibody. That overproduced clone is called a paraprotein.
And what is this rogue IgM antibody doing?
In many of these DADS-like cases, that IgM antibody is specifically targeting a protein called myelin-associated glycoprotein, or MAG, which is found in the peripheral nerves.
Into MAG.
Yes, this condition is called anti-MAG neuropathy. Technically, anti-MAG neuropathy is considered a distinct disease from CIDP. It is driven by a different cellular mechanism, often related to a low-grade bone marrow disorder.
But it looks the same.
Clinically, in the exam room, it looks almost exactly like the distal variant of CIDP. Distinguishing the two requires specialized blood tests looking for that specific IgM antibody, because treating anti-MAG requires targeting the bone marrow clones, whereas standard CIDP treatments often fail completely.
Okay, so we have typical CIDP, we have the patchy asymmetrical MADSAM, and we have the distal feet and hands DADS variant that might actually be anti-MAG. What else is hiding under this umbrella?
We have what we call the pure variants. First is pure motor CIDP. This is a phenotype where the patient experiences pure, unadulterated motor weakness.
Just weakness.
Right. Their muscles fail, they cannot lift things, they cannot walk, but they have absolutely zero sensory symptoms. No numbness, no tingling, no loss of sensation to temperature or pain. The immune system is selectively sparing the sensory nerve fibers.
And the mirror image of that must be pure sensory CIDP.
Exactly. Sensory CIDP, also known as CISP, chronic immune sensory polyradiculopathy. These patients present with the exact opposite.
Just the sensory side.
They have profound sensory symptoms. Crippling numbness, burning neuropathic pain, or severe sensory ataxia and balance loss. But their motor strength, when you push against their arms or legs in the clinic, is completely normal.
But wait, if they have completely normal strength, how do you know it's CIDP, which we defined as a demyelinating disease? I mean, shouldn't demyelination cause weakness?
This is a fascinating neurological quirk.
Yeah.
Even though the sensory patients have normal clinical strength, if you run specialized electrical tests on them, you will often find hidden, silent damage in their motor nerves.
Oh, wow.
The demyelination is happening to the motor nerves, but it just hasn't reached the critical threshold required to cause physical weakness yet. The body is just compensating.
That's wild. And then there are the incredibly rare geographical variants like focal CIDP.
Very rare, but they exist. In focal CIDP, the immune-mediated demyelination is restricted not just to one limb, but sometimes to a single nerve plexus, like the brachial plexus, which is the network of nerves in the shoulder that feeds the arm.
So just one specific area.
A patient might just have weakness and numbness in one single arm for years. It can stay localized to that one spot indefinitely, or terrifyingly, it can act as the harbinger of a massive diffuse attack that spreads to the rest of the body a decade later.
We've talked a lot about the physical variants, but finally we have to mention the time frame variant, because at the very beginning we defined CIDP as chronic, taking over 8 weeks to develop.
Right.
But the clinical data notes something called acute onset CIDP.
Yes, and this variant causes immense anxiety in hospitals. Up to 16% of patients who eventually receive a CIDP diagnosis actually present with a rapidly progressive course.
So it's fast.
They go from perfectly healthy to severely paralyzed, reaching their worst point, their nadir, in under 8 weeks. Often they peep in just 3 or 4 weeks.
But hold on, if it paralyzes them in under 4 weeks, doesn't that perfectly fit the definition of Guillain-Barré Syndrome? How do you even tell them apart in the emergency room?
In the emergency room, you usually can't. Initially, an acute onset CIDP patient looks exactly, indistinguishably like a GBS patient.
Really?
The distinguishing factor is only revealed by the passage of time and the response to treatment. GBS is typically a monophasic illness. It means it happens once. The immune system attacks, the patient hits rock bottom within a month, and then over the next several months or years, they slowly recover.
So what happens with the acute onset CIDP patient?
If a patient is diagnosed with GBS, but they continue to actively deteriorate beyond the 8-week mark, that is the first massive red flag.
Okay.
Or, very commonly, they are given a treatment for GBS, like IV2, and they improve rapidly. The doctors celebrate, but then a month later, the treatment wears off and they crash again. They relapse.
Oh, it's heartbreaking.
These are called treatment-related fluctuations. If a GBS patient relapses multiple times, the diagnosis must be officially shifted to acute onset CIDP. The immune attack wasn't a one-time event. It is a chronic, ongoing state.
Waiting to see if a patient gets paralyzed again just to get the right name on their chart is agonizing. But listening to all these variants, pure motor, pure sensory, asymmetrical, distal, acavinate, it raises a huge question. If a variant is purely motor and another is purely sensory, how can we confidently group them under the same CIDP umbrella? Aren't we just lazily lumping totally different diseases together because we simply don't know what else to call them? A purely sensory neuropathy doesn't seem to have anything in common with a purely motor one.
That is one of the most hotly debated questions in the global neurological community right now.
Yeah.
Some leading researchers argue exactly what you just said, that we are guilty of lumping when we should be splitting.
Okay, so I'm not crazy for thinking that.
Not at all. They argue that pure motor CIDP and pure sensory CIDP represent fundamentally different pathological diseases that deserve their own independent classifications.
So why keep them together?
They are currently kept under the broad CIDP umbrella for two main reasons. First, despite the outward clinical differences, they all share the same underlying electrophysiological hallmark-acquired immune-mediated demyelination of the peripheral nerves. The myelin is being attacked in all of them. And second, crucially, from a pragmatic standpoint, they often respond to the same broad-spectrum immunomodulatory treatments.
But not always. And this is the terrifying part of the chameleon nature of the disease. The clinical danger here is that misdiagnosis is incredibly common. And mistaking one of these CIDP variants for a look-alike disease can actually be disastrous for the patient.
Exactly. The stakes for getting the specific variant right are incredibly high. Let's look closely at the pure motor CIDP variant. It presents with only motor weakness.
Right.
There's another completely separate autoimmune disease called multifocal motor neuropathy, or MMN. MMN also presents with pure motor weakness, usually starting asymmetrically in the hands and forearms.
They sound identical.
Clinically, they can be nearly impossible to distinguish at first glance, but distinguishing motor CIDP from MMN is absolutely critical for the patient's survival.
Why?
Because corticosteroids like high-dose prednisone, which is a standard, cheap, first-line treatment for almost all forms of CIDP, can actually significantly permanently worsen the symptoms of pure motor CIDP.
Worsen it.
Yes. And furthermore, steroids do absolutely nothing to help MMN. In fact, they might accelerate it. If a doctor misdiagnoses a patient, assumes they have typical CIDP when they really have the pure motor variant or MMN, and prescribes a heavy course of steroids, they could actively accelerate the destruction of the patient's nerves.
Wow. So the doctor is walking a diagnostic tightrope, and they are essentially blindfolded by the overlapping symptoms.
It's a very apt metaphor.
Given that CIDP can look like a dozen other conditions, how do doctors actually prove a patient has it? How do they lift the blindfold? You can't just look at a patient and know. We have to dive into the detective work. What is the actual diagnostic toolkit used to catch this chameleon?
Because the clinical symptoms are so unreliable, the absolute cornerstone of a definitive CIDP diagnosis relies on looking at the electrical properties of the nerves themselves. This is done through electrodiagnostics, specifically nerve conduction studies, or NCS.
Walk us through what that actually is. What does a nerve conduction study feel like for the patient?
It is not a particularly pleasant experience.
I can imagine.
The patient lies on an exam table. A neurologist or a specialized technician places small recording electrodes, like little sticky patches, over specific muscles on the patient's hands, arms, feet, and legs. Then, using a stimulating probe, they apply small, sharp electrical shocks directly to the nerve overlying the skin at various points along the limb.
They are artificially firing the nerve.
Yes, they are injecting an electrical current to force the nerve to send a signal to the muscle. And the computer measures exactly how fast that signal travels down the limb and how strong the resulting muscle twitch is.
And what are they looking for on that computer screen? Like, what does a stripped wire actually look like in data?
The European Academy of Neurology and the Peripheral Nerve Society, the EANPNS, published a set of heavily revised, extremely stringent guidelines in 2021 that define exactly what constitutes proof of demyelination.
Okay.
Remember our basic biology. Myelin is the insulation that allows electrical signals to travel incredibly fast via saltatory conduction, meaning the signal literally jumps rapidly from one node of Ranvier to the next.
Right.
When that myelin insulation is chewed away by macrophages, the signal loses its ability to jump. It slows down drastically. Or the electrical charge leaks out into the surrounding tissue and stops entirely.
So the test is measuring the speed and the volume of the signal.
Exactly. On the nerve conduction study, the neurologist is hunting for 4 specific electrophysiological red flags. First, they look for prolonged distal latencies.
Latency meaning a delay.
Yes, It means it takes entirely too long for the electrical signal to get from the final stimulation point near the wrist or ankle down into the actual muscle of the hand or foot. The signal is dragging.
What's the second red flag?
Second is a broadly reduced conduction velocity. The overall speed of the signal traveling down the long segments of the forearm or the lower leg drops significantly.
How much of a drop?
To meet the strict 2021 diagnostic criteria, the guidelines require a slowing of more than 30% below the established lower limit of normal, and this must be seen in at least two different nerves.
30% is a massive drop in speed.
It is.
What is the third thing they look for?
Third, and this is a brilliant piece of diagnostic ingenuity, we look for prolonged F waves.
F waves. Okay, we need to unpack this because this sounds like highly complex neurophysics. What exactly is an F wave?
It is incredibly clever. When you take that probe and stimulate a motor nerve on a patient's wrist, the bulk of that electrical signal travels straight down the short distance into the hand to make the thumb twitch. That is the primary response.
Makes sense.
But a smaller portion of that electrical charge actually travels backwards.
Backwards, up the arm.
Yes, it travels antidromically against the normal flow, all the way up the nerve in the arm, through the shoulder, into the nerve roots right next to the spinal cord, bounces off the anterior horn motor cells inside the spinal cord, and then travels all the way back down the entire length of the arm to cause a second tiny delayed twitch in the thumb.
Wait, really?
Yeah, that massive round-trip electrical echo is called the F wave. It gets its name because it was originally recorded in the foot muscles.
That is amazing. So it's an electrical echo, but why is it so useful for finding CIDP?
Because of the anatomy of the disease. Remember, CIDP is polyradiculoneuropathy. Much of the most severe inflammation and demyelination happens proximally way up deep in the nerve roots, right next to the spine, where the blood-nerve barrier is naturally a bit weaker.
And you can't exactly just stick an electrode into someone's spine to test those roots.
Exactly.
Yeah.
We can't reach those deep nerve roots with our standard surface stimulation probes. But the F wave travels the entire length of the nerve, including right through those deep spinal roots.
Oh, I see.
So if the myelin is stripped away up in the shoulder or the spine, the F wave echo will be significantly delayed in making its round trip. A delayed or absent F wave is a brilliant, non-invasive way to detect demyelination hiding deep inside the body where we can't see it.
It's literally like sending a sonar ping down a long, dark tunnel to see if there's a cave-in halfway down.
That is exactly what it is.
That is elegant. So we have latency, slowed velocity, and delayed F waves. What's the fourth electrical red flag?
The most definitive one, conduction block. This is the smoking gun of acquired demyelination. Imagine you stimulate a nerve below a suspected damaged area, say, at the wrist. And you get a nice, strong, tall waveform on the screen representing a healthy muscle twitch. But then you move the probe up the arm and stimulate the nerve above the damaged area, say, at the elbow.
So the signal has to travel through the stripped wire to get to the hand.
Precisely. And when it hits that segment where the macrophages have completely eaten the myelin, the signal simply dissipates, it shorts out, the muscle response you record at the hand drops massively.
Oh, massive.
The guidelines require a sudden reduction of at least 30% in the signal's amplitude or size between the two stimulation points. The signal simply cannot make it past the blockade.
Okay, so electrodiagnostics are the heavy lifters, but they aren't the only tools in the detective's kit. Sometimes the shocks don't give a perfectly clear answer. What about drawing fluid?
Cerebrospinal fluid analysis, or CSF analysis, is highly supportive. This requires performing a lumbar puncture, commonly known as a spinal tap. Yeah, the doctor inserts a long needle into the lower back to draw out a small amount of the fluid that bathes the spinal cord and brain. We send that fluid to the lab to look for a classic diagnostic pattern called albuminocytologic dissociation.
Let's translate that medical Latin for everyone. Albumin is protein, cyto is cell.
Exactly. It's a fancy, intimidating term that describes a very specific, simple ratio. It means the protein levels in the patient's spinal fluid are abnormally high, often greater, sometimes much higher. But the white blood cell count remains completely normal, usually less than 10 cells per cubic millimeter.
High protein, normal cells.
Right.
But why does that specific pattern point to CIDP? Like, why wouldn't there be white blood cells if the immune system is attacking?
Because of the location of the attack. In a typical viral or bacterial infection of the nervous system, like meningitis, the spinal fluid would be absolutely swarming with thousands of white blood cells rushing in to fight the infection.
Okay, that makes sense.
But CIDP is a localized attack on the nerve roots. The intense inflammation in the nerve roots damages the local blood vessels, causing them to leak large blood proteins, like albumin, directly into the spinal fluid. But because it's an autoimmune process focused on the myelin, not a widespread infection, it doesn't trigger a massive influx of free-floating white blood cells into the fluid itself. High protein without the cell swarm strongly suggests immune-mediated demyelination at the nerve roots.
Shocks spinal fluid. What about just taking pictures? Can we physically see the damage with modern technology?
Yes, and this is an area that has advanced massively in the last decade. Imaging is becoming incredibly useful. High-resolution MRI or specialized nerve ultrasound can actually visualize the peripheral nerves in striking detail.
What does a damaged nerve look like?
In CIDP, because of the chronic ongoing inflammation, the tissue edema, and the repeated cycles of the body trying to repair the myelin and the immune system destroying it again, the nerve roots or the large plexuses will often look physically enlarged.
So they swell up.
They become massively swollen compared to healthy nerves. Furthermore, if you do an MRI and inject a contrast dye called gadolinium into the patient's blood, the damaged nerve roots will literally light up on the scan.
Really?
They will show active enhancement, which visually proves to the doctor that the blood-nerve barrier is currently breached and actively leaking the dye into the nerve.
So you have the shocks, the fluid, the images, but the detective work isn't just about proving CIDP is there. It's about proving the villains wearing the CIDP mask aren't there. We mentioned the mimics. What else looks like CIDP but requires completely different treatment?
A huge part of the diagnostic process is ruling things out. We already discussed anti-MAG neuropathy masquerading as the distal variant. There's also a severe systemic disease called POEMS syndrome.
POEMS, that's another acronym. Polyneuropathy, organomegaly, endocrinopathy, monoclonal protein, and skin changes.
Yes. The P in POEMS stands for polyneuropathy. And on a nerve conduction study, the demyelination in POEMS can look remarkably similar to CIDP. The electrical signals slow down in much the same way. But clinically, if you look at the whole patient, there are major differences. Severe burning pain is often a highly prominent early feature in POEMS, which is much less common in typical CIDP. POEMS patients also suffer from massive systemic issues, profound fluid accumulation in their legs, grossly enlarged organs like the liver or spleen, and widespread endocrine gland failures.
What happens if you miss those signs and treat them for CIDP?
It's a disaster. If you misdiagnose POEMS as CIDP and give them standard immune therapies like IVIg or steroids, it does absolutely nothing to stop the disease.
Oh, wow.
POEMS is driven by a deadly overproliferation of plasma cells in the bone marrow. To save a POEMS patient, they need aggressive, targeted treatment for that underlying plasma cell disorder, often requiring chemotherapy or an autologous stem cell transplant. Giving them standard CIDP drugs just wastes precious time.
And then there is the genetic trap. The literature we reviewed highlights a truly striking, almost unbelievable statistic. 3.2% of patients who are formally diagnosed with CIDP by neurologists and who are actively undergoing treatment for it actually turn out to have a genetic Charcot-Marie tooth mutation instead, CMT.
That statistic is a humbling reminder for every diagnostician. It means roughly 1 in 30 CIDP patients actually has a completely different disease.
That's high.
It is. CMT is a hereditary neuropathy. It is hardwired into your DNA. You were born with it. But here is the cruel trick. Certain genetic subtypes of CMT, specifically CMT type 1 or CMT type X, cause the Schwann cells to build defective myelin from the start.
So it looks demyelinated.
Exactly. And when you run nerve conduction studies on these genetic patients, they show profound slowing and even conduction blocks that perfectly mimic the acquired immune-mediated damage of CIDP.
How does a doctor spot the genetic imposter then?
You have to pull your eyes away from the computer screen and look at the patient's history and their physical body. CMT patients usually have a much, much younger age of onset. They're often reporting clumsiness since childhood.
Okay.
Because the subtle genetic muscle weakness has been present for decades, it alters the physical development of their skeleton. They frequently have prominent visible deformities like massive high arches in their feet called pes cavus or hammer toes where the toes curl downward. The long-term weakness pulls the bones out of alignment.
And what happens if you treat a CMT patient for CIDP?
This is the biggest red flag. They will show absolutely zero response to immunotherapy. You can pump them full of high-dose steroids, you can give them months of expensive IVIg infusion, and they will not improve one single bit. Because their immune system isn't the problem at all. The blueprint in their genes is the problem.
Hearing all these pitfalls, I have to jump in with a major question. I see in the diagnostic guidelines that nerve biopsies are listed as an option. The surgeon physically cuts out a tiny piece of the sural nerve, which is a sensory nerve down in the calf, and a pathologist looks at it under a microscope.
Right?
And when they do, they can actually see what are called onion bulb formations.
Yes. Onion bulbs are concentric layers of Schwann cell processes. They form when a nerve is repeatedly demyelinated by the immune system, and the Schwann cells desperately try to remyelinate it over and over again, creating layers that look exactly like a cross-section of an onion.
Right. So if an onion bulb is definitive, physical, microscopic proof of chronic demyelination, why in the world are we messing around with all this guesswork? Why do the electrical shocks, the spinal taps, the MRIs, and risk misdiagnosing a mimic? Why isn't a nerve biopsy the very first thing we do on day one? Just look at the nerve.
It's an entirely logical thought process, but in clinical practice, a nerve biopsy is considered a weapon of absolute last resort for two major reasons. First, there is the morbidity of the procedure itself. You are surgically severing a living sensory nerve. Yeah, that leaves the patient with a permanent patch of complete numbness on the side of their foot.
That's not great.
No, and furthermore, many patients develop a painful neuroma, a tangled knot of sensitive nerve endings at the surgical incision site that can cause chronic pain for the rest of their lives. You are intentionally causing permanent nerve damage to diagnose nerve damage.
That is a very high price to pay just for a diagnosis.
It is. But the second reason is even more frustrating. The diagnostic sensitivity of a sural nerve biopsy is actually surprisingly low.
Meaning it often misses the disease. How?
Remember the anatomy. We said CIDP is notoriously patchy, and the most severe inflammation is usually located proximally, way up in the large nerve roots near the spine.
Right.
The sural nerve that we biopsy is located distally, down the ankle. It is entirely possible and quite common that the severe inflammatory stripping simply isn't happening in the tiny 3-centimeter piece of nerve you decided to cut out.
Oh, wow.
You could put the patient through the surgery, cause the permanent numbness, put the nerve under the microscope, and find absolutely nothing abnormal, even though the patient has raging severe CIDP, destroying the nerves in their shoulders and hips.
So it's literally a shot in the dark.
Exactly. Therefore, modern guidelines strongly recommend against routine biopsies. They're usually only performed when the clinical picture and the electrodiagnostics are borderline, and we desperately need to definitively rule out other severe tissue-based diseases like amyloidosis or vasculitis, where getting a physical piece of tissue is absolutely mandatory to save the patient's life.
Okay, so the detective work is rigorous and fraught with traps. But let's say you've navigated the clinical chameleon. You've run the gauntlet of nerve conduction studies, you've analyzed the spinal fluid, you've ruled out the genetic mimics and the systemic bone marrow diseases. You finally have a confirmed, rock-solid diagnosis of CIDP.
The diagnosis is secure.
The internal demolition crew is actively destroying the house wiring. How do we stop them?